Remember the love we share. Embrace the friends who care. Celebrate the life we live. Give all that we can give today.
And if it's the fact that there's problems in sleep that create this problem, then it really makes us want to say, yeah, let's go ahead and look why this could be what could be involved here. So the growth hormone was the first hormone that was linked with deep sleep. We know that when you're in deep sleep, you make growth hormone. Growth hormone is involved in tissue repair. So if you would have disrupted deep sleep, you might have disrupted growth hormone. And we actually know that if someone has growth hormone deficiency, that looks a little bit like fibromyalgia. Now, over 90% of patients in my practice have problems with non-refreshing, non-restorative sleep. And what we see is that there are problems with their sleep. In the last lecture, I mentioned this as well. This is the science from Harvey Moldavsky, considered really to be the sort of the seminal or first scientific article on fibromyalgia, because he noticed that they have this alpha wave intrusion during their deep sleep. And he was so convinced that this alpha wave intrusion during their deep sleep was a problem that he took healthy college students and he sort of selectively deprived them of deep sleep by ringing a little bell whenever they got into their deep sleep. So he kept them asleep, but only in light sleep and dream sleep. They didn't get into deep sleep. And after a couple of days, they developed diffuse musculoskeletal pain and cognitive impairment. Basically, he induced fibromyalgia by So this, by just depriving them of deep sleep. So in this particular slide, what we're seeing is a polysomnogram. So up here, we see the deep waves, and these are right here. So this tells us that we're in deep sleep. And this is your eye movements, your chin, muscle tone, EKG, heart rate, leg movements, snoring, airflow. So this is what we look at when we do a sleep study. And these are the brain waves of deep sleep. But in patients with fibromyalgia, it looks like this. So clearly you can see that there's a difference between that and that. But there's a problem, because the way currently sleep labs score is according to a very old criteria called the RNK criteria, and all they do is they measure these deep waves. So if you have those deep waves, you automatically have deep sleep. So in a typical sleep lab, this would represent deep sleep, and so would that. There would be no difference in how the sleep physician would score that, because they don't count the alpha waves. That's not part of the official criteria. But people who study fibromyalgia clearly see that there's a big difference between this and that. Now, alpha waves are what we have when we're awake. So the idea is, even though patients with fibromyalgia are technically sleeping, their brain actually electrophysiologically appears like they're more awake. So here's what a normal sleep cycle is supposed to look like. You start off in wake and you go into what's called light sleep, stage 1 and 2, then into deep sleep, stage 3 and 4. And really we pile this together in the same category. We just call this slow wave sleep now. And then up into REM. Now people think of REM as their deep sleep, but that's actually incorrect. REM, rapid eye movement, is when your mind is dreaming. If we look at the brain waves, it's identical to being awake, but your body is paralyzed. So you cycle into deep REM, and then a little bit of deep. After about 4.5 hours, you do not get any more deep sleep. So you have one and only chance to get your deep sleep, which is the first part of night. In the early morning hours, you get your REM sleep. And the idea is, deep sleep is very restorative for your body. You're making neurotransmitters, hormones, all kinds of things. REM sleep, we think, has something to do with the mind, mental processing, memory, stuff like that. People with depression have more REM sleep. Most antidepressants block REM sleep. But we don't really know. We do know that deep sleep is very refreshing and restorative for the body. So what are these alpha intrusions? So the problem is because it's not part of the official criteria, we don't really know what to call it. So Harvey Moldavsky called it alpha intrusions. Other researchers have called it the alpha anomaly. Other people have called it the alpha abnormality. There have been some recent papers about whether it's called tonic or phasic. In other words, it's present throughout the entire study or it comes and goes. Alpha delta has kind of caught on recently. So I sort of said, I don't really know what to do with all that. So why don't we just use computers and let the computer figure it out? So here's a 30-second epoch of a sleep study from my lab, and what you see here is the computer is figuring out all these alpha waves. Now clearly this person is in deep sleep. You can see these deep waves, but there's a penetration of these faster frequencies. So if there's enough of these faster frequencies, our computer measures it. And then we can graph it out at the very end of the study and see what it looks like. So in this slide, this is another example. So if you remember, this would be deep sleep and this is REM sleep. Now, this particular person has severe sleep apnea. Sleep apnea, which we're going to talk about in a second, they stop breathing. This person stops breathing about 100 times an hour. Their heart is fibrillating. They're not getting any deep sleep or REM sleep. His oxygen is desaturating to 70%, which is very, very bad. But up at the top, we have alpha and delta. And you can see that this person still is getting delta sleep all night long, even though he has a death-defying type of a sleep apnea problem. But look at the alpha. No problems with alpha at all. So even though this person has very, very severe, very life-threatening sleep problems, there's no alpha penetration. Now, I want you to keep an eye on this top line, because the next slide is someone who was a normal sleep patient at another lab. But you can see that there's alpha penetration throughout the entire night. You see that? So even though there's no sleep apnea, there's no heart rate problems, there's no oxygen problems, this would be sort of defined as a normal study. But we're seeing significant problems with alpha penetration throughout the entire night. So I actually got to present some of this data at the International Federation of Clinical Neurophysiology, which happened to be in Cuba 2 years ago, which was another story in and of itself. But they asked me to see if we can actually use this as a marker not only to identify patients with fibromyalgia, but a response to how can it measure a response to treatment. And that's what we did. So here's a patient before, and you can see that they have this alpha wave penetration all night long, and we added an experimental medication called sodium oxybate. And the line gets better. So that was data that we presented there. We then followed that up with a study that we presented at the National Fibromyalgia Research Association in 2008 in Portland. And they were onto this idea of fibromyalgia and sleep for a while. The conference was called Fibromyalgia and Sleep Disorders. We got to present some data where we took a number of patients and repeated that. And so what I decided to do is just take that delta alpha ratio and make that into a number. So and what we found out is that the vast majority of patients with fibromyalgia had a very low number. Patients without fibromyalgia had a very high number. And that data is going to be forthcoming. But what we did is said, okay, these are patients with fibromyalgia who have a very low delta alpha ratio. Let's go ahead and add this experimental medicine, sodium oxybate, and see what happens. Well, in each case, we were able to improve their delta alpha ratio. And in each case, the pain decreased. So this is a very interesting study in that we were able to show that sodium oxybate may be an effective treatment for patients with fibromyalgia, that the improvement in sleep and pain supports the association of there being a connection between sleep and pain, and that you can use quantitative brainwave analysis not only to identify these patients, but to measure a response to treatment. Yes?
What is another name for sodium oxybate?
Xyrem.
Xyrem?
XYRAM. Otherwise known as GHB, gamma hydroxybutyrate. So thank you for that introduction there. So gamma hydroxybutyrate was known as the date rape drug. Probably as effective a date rape drug because it puts you into deep sleep. So if anyone has children to know that when they first go to sleep, it's like impossible to wake them up. That's deep sleep. So during deep sleep, you can't get up and go drive or whatever. You're pretty much out. So it's inducing deep sleep. It's the one chemical that we know that induces deep sleep. Now, a lot of people don't know this, but gamma-hydroxybutyrate is an endogenous compound. In other words, your brain makes GHB. It probably either is the direct signal to go into deep sleep or its immediate precursor, but in either case, it is a natural compound that puts you into deep sleep. Now, it's what's called a GABA-B receptor agonist. Now, most of the benzodiazepines that are things like the Ativan, Valium, Xanax category affect the GABA-A. Things like Ambien, Lunesta, those sleeping pills also affect GABA-A. Those medications actually over time will rob you of your deep sleep. We already know that deep sleep is a problem in fibromyalgia, so now we're giving you guys medications that may actually be worsening or perpetuating the problem. But this medication, because it works with GABA-B, actually significantly improves deep sleep. The other thing that's very interesting about it is that patients who take GHB will have a significant increase in their growth hormone. And if you remember, we talked about growth hormone being another identifier of bad sleep and being very low in patients with fibromyalgia. So now we have this chemical that replaces not only your deep sleep, but your growth hormone. And it's not doing really anything to your pituitary. It's just telling you to go into deep sleep. And when you're in deep sleep, you also make your growth hormone. So that's another way of measuring what's going on. So I want to tell you about the phase 3 trial that we participated in. So they said, okay, this is very interesting, so let's actually do a big trial. This medicine is currently FDA approved for patients with narcolepsy. But fibromyalgia is present in 2% of the population. So this company would be really excited if they got approved for something that's probably 20 times as common as what they're currently indicated for. In either case, we did a trial. There were 74 sites. This was what's called a parallel trial. So there was the same design over in Europe. So between the 500 plus we had here and the 500 plus we had in Europe, we're talking about over 1,000 patients who were studied according to this protocol, which is really exciting because when you get those kinds of numbers, you can really generate some very good data. It cost the company over $100 million, but that's the cost of doing medical experimentation now in the United States. And so what we did is we took 3 groups. A placebo group, a group that did 4.5 grams a night and 6 grams a night. The first week, you screen them. The next week, the next month, we washed them off. They had to be off of any other type of medication that could affect fibromyalgia. No Lyrica, no Cymbalta, no sleeping pills, no narcotics, nothing. So we had a true baseline. Then we started them on the medication. That went on for about 14 weeks, within a couple of weeks after that to follow them up. So that was the design of the trial. The primary outcome was pain. Why? Because the current FDA approval for fibromyalgia is only pain. It doesn't matter that patients complain of sleep and cognitive impairment and morning stiffness. Too bad. The current indication is pain, so you have to show an improvement in pain. We're giving them a sleep drug, so it's a bit risky, but that's what they did. So the primary outcome is what's called a pain visual analog scale, greater than 30% reduction. That's the current sort of standard in the industry. But they looked at other outcomes as well. What's called the functional impact questionnaire, fatigue scores, global impression of change, sleep scores. These 2 are sleep scores. So, and what it showed, I'm sorry I have to kind of peer over here, but what it showed with the pain score is that compared to placebo, with a 30% reduction in pain was present in over 50, almost 60% of the patients. So by giving these people just the sleep medication, there was an improvement in pain in almost 60%. And if you talk about people who had over a 50% reduction, we're talking about almost 45% had over a 50% reduction in pain. So that's pretty exciting results. What this shows is that within the first week, there was already a statistically significant difference between the placebo arm and the treatment arm with pain. And that statistical significance was maintained through the entire length of the study. Besides the improvement in pain, they looked at fatigue. And the improvement in fatigue paralleled the improvement with pain. And again, statistically significant improvement in both of the treated groups compared to placebo within the first week of the study, which is very unusual, actually, for these medication trials. And again, the fatigue improvement was maintained through the entire length of the study. This is actually the only medication that I'm aware of that's been shown to have a statistically significant improvement in fatigue that was maintained for over 14 weeks in any large double-blind placebo-controlled trial. And this is the Jenkins sleep score. So the higher the score, the worse your sleep. So you want to have a negative score on Jenkins. And what it shows compared to placebo, the groups with both treatment arms had significant improvements in their overall sleep scores. So the same medication which is improving their pain and their fatigue is also helping their sleep. And we would expect that because it's a sleep medication. There's a new thing in vogue called this composite responder index over time. And this is where they combine, okay, if you were a sleep responder plus a pain responder plus an overall functional responder, what were the chances that you were in all three groups? In other words, you had improvement to pain, sleep, and function. And what they showed that there was a statistically significant improvement that actually correlated a little bit more with the doses. So the higher the dose, the better the chance that you were a responder in all three groups, what's called a composite category. In terms of side effects, headache was present in about 23% in the highly treated group. Nausea present in about 14 to 21%. That's pretty significant because if you look at the SNRI data, that's the Cymbalta and the Savella, this number is about 40%. So it's half the rate of nausea as some of these other commercially available drugs. Dizziness, vomiting, diarrhea, anxiety, lesser percent, so usually less than 10%. But there are side effects like any other medication. So they show that there's improvement in fatigue, sleep, functionality, quality of life, patient global impression of change, as well as meeting the primary endpoint of pain. It was pretty well tolerated. Adverse events were similar to the phase 2 trials and what we know from the narcolepsy population. And the most common side effects were headache, nausea, dizziness. And so I'm going to move on now to other treatments for the sleep-related problems of fibromyalgia. We know that a lot of patients have restless legs. We're going to talk about that in a second, about pramipexole. In terms of treating the general sleep problems, there have been studies looking at soma or cyclobenzaprine, muscle relaxant, zolpidem, Ambien, escopine, Lunesta, melatonin, and again sodium oxybate, with the comment that sodium oxybate appears to be particularly efficacious in terms of the pain as well, whereas these other ones do not. And we again think that has to do with the improvement in deep sleep. So I'm going to move on to insomnia here. A lot of patients with fibromyalgia complain of difficulty initiating, maintaining sleep, and that this is probably due to a combination of neurochemical, hormonal, psychological problems, probably sleep environment as well. Practicing good sleep hygiene is very important. Having a regular bedtime, not spending too little or too much time in bed, having a comfortable sleep environment. Maybe avoiding the husband that's snoring too much. Could be also part of the problem. Sometimes you have to treat the patient's spouse to treat their sleep problem. You got to be careful with certain sedative hypnotics. Things like Benadryl can be very effective. They're very cheap. They're pretty well tolerated. They're pretty long lasting. They're not addictive, but it can worsen restless legs. So you have to be kind of aware of those sorts of interactions. The problem with benzodiazepines, such as anything from Xanax to Ambien, is they're pretty well tolerated. They work pretty good, except really we think of them as short-term drugs because over the long term they can be addictive and they can actually rob you of your deep sleep. Things that we can use in fibromyalgia that worsen sleep and insomnia. Well, beta blockers probably, and those are things like propranolol, Indorol. We use those for heart problems, high blood pressure, heart failure, palpitations. So beta blockers can impair your melatonin production and cause insomnia. The Cymbalta Savella drugs can worsen insomnia and restless legs in 10 to 20%. Stimulants, energy drinks, which are consumed a lot by patients with fibromyalgia for fatigue problems, can certainly worsen their insomnia. And then stress, elevated cortisol, is probably the worst thing you can do for your insomnia. No way to combat that unless you just work on stress reduction. So I'm going to move on now to sleep-disordered breathing. So sleep apnea is a pretty hot diagnosis right now. We're making that diagnosis in a lot of people. So the idea with breathing is that you want air to enter your body. Once the air enters your body, it goes to the lungs, and then you make oxygen, and we're pretty sure, I know this is a bit of a scientific stretch, that oxygen is a good thing to have around most of the time. We're pretty comfortable in saying that. So in sleep apnea, the problem is the muscles in the back of the throat get too relaxed, or the neck is too wide, or there's too much weight, or for whatever reason, this tissue collapses. Air can't get into your body, you can't make oxygen, that's probably a bad thing. And why is it a bad thing? Well, so your airway collapses, your oxygen goes down, your carbon dioxide goes up, your fight or flight sympathetic nervous system activates to make a bunch of adrenaline, which is the last thing you want at night. Your adrenals start to pick it up. Your adrenals start to make cortisol, which increases your weight, which increases your glucose intolerance, which increases problems with insulin resistance. Your heart rate goes up, your blood pressure goes up, and this is all when your blood pressure and hormones are all supposed to be nice and relaxed. And this happens again, you have this what's called a microarousal. When you have a little microarousal, your throat opens, you like that, and you start to breathe again, you go right back to sleep, your airway collapses, your oxygen goes down, your fight or flight goes up, it happens again and again and again and again, sometimes 100 times an hour. So here's a patient with, and I'm going to be allowed to tell you this because Lynn said I could, but this is actually Lynn Manalana, the head of the National Fibromyalgia Association. And I was expecting to see alpha delta sleep, which we do. Remember the top line? She's got alpha delta sleep. And my jaw dropped when I saw that she actually had severe sleep apnea. So this is not a disease of patients who have wide necks or high body mass indexes only. This can be seen in anybody, men, women, young, old, thin, overweight, it doesn't really matter. In her particular problem, this is REM state, so she has what's called a REM-specific severe sleep apnea syndrome, in association also with alpha delta sleep. So just because you have fibro doesn't mean you can't have an other sleep disorder, which is treatable in a different way. So what do we do? Well, a lot of patients use what's called CPAP, continuous positive airway pressure. It's basically a fancy pump or blow dryer that takes air, room air, pressurizes it between 5 and 15 centimeters. There's some type of a mask or something, and then the pressure just creates a stent, which keeps the airway open. Air enters your body. Once air is in your body makes oxygen, and everyone's happy. The problem is a lot of patients with fibromyalgia, as we know, have this non-refreshing, non-restorative sleep, difficulty getting to sleep. And the last thing they want to do is have a Darth Vader mask on their face. So what do we do? Well, we got to treat them. There's other options, okay? There's oral appliances, which are made by dentists. The idea here is it just moves the bottom jaw out a little bit. By doing that, air is able to enter the body. So that can be an option. Unfortunately, even though it is FDA approved for mild and moderate sleep apnea, it's not always so easy to get the medical insurance plan to pay a dentist anything. It's also not so easy to get the dental plan to pay for something that's a medical diagnosis. So the patient gets stuck in the middle. Yes?
On the previous slide, where this mask was used,
Yeah.
Still, it's covering the nose.
Right.
And when it's covering the nose and you open your mouth, then the
It
air
goes out,
escapes.
not down. Right.
Yeah.
So you either have to put in a chin strap, learn to keep your mouth closed, or do a mask that covers both the nose and the mouth. So that's exactly right. Unfortunately, I'd say about 80% of people who use a mask end up using just a nasal mask, but about 1 in 5 have to go with a full face mask. But again, some patients are candidates for oral appliances and other, but some rarely surgical. So I'm going to move now into restless legs, very common. There's restless legs, there's periodic leg movements. They're actually two distinct entities. They do overlap, though. We diagnosed this during a sleep study with periodic leg movements. Greater than 15 per hour is sort of now the industry opinion that this is probably significant, or greater than 5 an hour in the pediatric population, if it always also corresponds to a disturbance clinically of their sleep. In other words, if your legs are beating 20 times an hour and it just pisses off your spouse, well, we don't consider that clinically significant for you, per se. Others may beg to differ with that. It tends to be very responsive to the dopa agonists, which are the drugs for Parkinson's, as well as the muscle relaxants and benzodiazepines. Periodic leg movement is seen in about 80 to 90% of the time when we do see restless legs, but you can have restless legs without periodic leg movements and vice versa. Restless legs, however, is a very, very common syndrome, probably seen in about 15% of the population. It was actually first described by this guy, Sir John Willis, as night crawler syndrome. It was then, the term actually restless legs was coined by a researcher named Ekbom in the 50s. There's a lot of he did a lot of publications. He actually correlated this with iron deficiency, and he was probably right. And he probably said this is present in 15% of the population, which is a huge number, but it's probably right. So in this room, theoretically, about 5 of you should have restless legs. So it's diagnosed by just clinical symptoms. You do not need a sleep study or a blood test to diagnose restless legs. You have to have, though, all 4 of these symptoms. This urge to move your legs associated with an unpleasant sensation, a worsening of symptoms with rest, an improvement of symptoms with movement and getting up, and symptoms tend to be worse in the evening. Those 4 symptoms, and you've basically got restless legs. So some of the symptoms can include, let me see, So besides this kind of urge to move that gets worse at night, we know now it's also associated with other feelings, kind of burning, tingling, aching. The arms can be affected. So this is why we really think about it in fibromyalgia, because some of the symptoms can look like some of the fibromyalgia symptoms. There's ways that you can test for it in a sleep lab. One thing I would say is that you would probably also want to see a neurologist, maybe get an EMG nerve conduction study, because sometimes it can be due to peripheral neuropathy, a disease of the nerves. And you also probably want to get some blood tests. It has been associated with iron deficiency, so if you have low ferritin levels, this can be very easily treated. Like I said, it is associated with iron deficiency, can be associated with thyroid problems, peripheral neuropathy, lumbar radiculopathy, attention deficit disorder, and it's present in about 30 to 40% of people with fibromyalgia, so double the non-fibro population. There can be a family history in upwards of 50% of patients with restless legs. It can occur as a sporadic genetic mutation, or it can be autosomal dominant, which means if you pass it on, your kids probably got it. And if it happens usually earlier in life, it's probably genetic. Later in life, it's probably more hormonal or metabolic. Here's a graph that shows about patients with restless legs without restless legs, and clearly there's a problem with ferritin and transferrin in this population. So these are things that are affected with iron. It is a cofactor for an enzyme called tyrosine hydroxylase, which means it has something to do with the way your brain synthesizes dopamine. What's interesting is we started using dopamine agonists in patients with Parkinson's for, 20 years ago. And sometimes they'd come back and say their Parkinson's was better, sometimes it wasn't, but they'd always say, "Doc, my restless leg is better." I said, "I didn't care, I didn't ask you about your restless legs, you're here for your Parkinson's." But after a couple decades of this, we actually started to listen. And now the medicines that we use for Parkinson's are also FDA approved for restless legs because they're so successful. And so what you're doing is you're basically bypassing the iron problem and just giving them the dopamine. There's been 3 sets of families that have been studied clearly that have an autosomal dominant pattern, and each of these genes have to do with either iron or dopamine. I'm going to move on here. It's important to understand that certain medicines that we use in fibro may worsen the restless leg part. We've talked about this. Benadryl, which is a great medicine for sleep in a lot of patients, will unfortunately worsen restless legs. The tricyclics, which are probably the most common thing written in fibromyalgia, will worsen restless legs. Cymbalta and Savella, which are FDA approved for fibromyalgia, will worsen restless legs. So you have to worry about sometimes the interaction of various medications on the other symptoms of fibromyalgia besides the pain. Quinine can be a very successful solution. Unfortunately, they took it off the market. I have no idea why. But you can still find it in tonic water. And so a little tonic water, with or without the gin, I guess, can be quite helpful. Magnesium, especially in higher dosages, can actually be successful for restless legs in a lot of patients. Exercise usually does help. And again, if you have a low iron or ferritin level, that's easy to test and easy to treat. There's a lot of medicines that actually work very well. Benzodiazepines work well. Some of the anticonvulsants like Depakote and Topamax work very well. Narcotics actually do work pretty good. And dopamine agonists, the medicines that we use for Parkinson's like Mirapex and Requip, are particularly effective at very, very low dosages. Let's talk a little bit about narcolepsy. This is a very rare condition, although I don't know why. It just seems to be hard to diagnose in people, even in sleep labs. These patients have 4 cardinal symptoms, which is excessive daytime somnolence. They're very, very sleepy all the time. They have a dreamlike, what's called hypnagogic or hypnopompic hallucination. Sometimes it occurs right when they go to bed or as they get out of bed, or sometimes in the middle of their day they can just start dreaming. They can have a sudden loss of muscle tone that's called cataplexy. It's typically triggered by some kind of an emotional trigger. Sometimes it's telling a joke or a little excitement, and they may lose the use of their legs or the use of their arm. And sleep paralysis, when they wake up, they feel like they're paralyzed, like they can't move. We now know that narcolepsy is associated with an autoimmune disease after a common strep infection. That if you measure the ASO titers, which are reactions to your strep bacteria, immediately after diagnosis of narcolepsy, it's very high. There's a little chemical in the hypothalamus, which is at the base of the brain, the sleep-wake center, called hypocretin. We call it hypocretin here. In Europe, they call it orexin. And we know now, though, that this autoimmune attack knocks out the hypocretin. And the hypocretin are like the little sleep police. They allow you to go from wake to light sleep, from light sleep to deep sleep, from deep sleep to light, from light to REM. They're very rigid about where you can go. So from one place you can go to the next. Without those little sleep police, you can do anything at any time. You can be dreaming in the middle of your day or fall into deep sleep in the middle of your soup. So this is the problem. We diagnose this in a sleep lab, not with a nighttime sleep study, but with a daytime sleep study. It's a series of 4 naps. And if you can take all 4 naps within 8 minutes and have 2 of those associated with a dream state or REM state, that's how we diagnose it. What's interesting is the medicine we talked about for fibromyalgia, sodium oxybate, is actually FDA approved for this condition. It's very successful. We also know that stimulants, which are commonly used in patients with fibromyalgia, can also help patients with narcolepsy. So there's a lot of connection between narcolepsy and fibromyalgia in terms of the treatments that appear to be successful. The cataplexy, or the sudden loss of muscle tone that we see in patients with narcolepsy, that same medication can also be very effective for patients' pain and sleep in fibromyalgia. So for reasons we don't quite understand yet, it's probably the closest condition in terms of the treatment overlap is actually narcolepsy. So I think this is a very interesting area for the future. So in terms of overall sleep and fibromyalgia, the big questions are, is your sleep non-refreshing, non-restorative? If so, are you a candidate for one of the new experimental therapies that we talked about? Do you have sleep apnea? Does that need to be tested and treated? That's easy to test and usually pretty easy to treat. Do you have restless legs? Another comorbidity. That can be easily, you don't have to test for that, that's just a symptom. That can be easily treated. Or is it the fact that may be related to another one of the medications you're taking for fibromyalgia? Do you have insomnia? Do you have good sleep hygiene? Are you doing what you need to do to get a good night's sleep? So some of the kind of recommendations we want to talk about are, having good sleep hygiene, have a nice wind-down routine. People with fibromyalgia have an elevated stress, cortisol-type problem, so you have to kind of be over-careful about reducing your stress, particularly around the evening time. You can't kind of do all your work and then pop into bed and expect to sleep. You have to manage your stress. If your cortisol levels are high, it doesn't matter what medicine I give you, you're not going to sleep. So managing stress is key to the sleep part of this problem. You want to, the restless legs is a comorbidity. You want to avoid medications that we will typically prescribe for fibromyalgia that will worsen the restless legs. You may want to consider a sleep study for the sleep apnea, the leg movements, these alpha intrusions that we talked about. Of course, you got to make sure that your sleep lab is aware about how to score and how to identify alpha intrusions. And if you do have either one or a set of sleep problems associated with fibromyalgia, to really develop a logical treatment approach, that's going to help. So with that's it. That's all I have, and I'm happy to take any questions. Thank you.
For somebody who doesn't have sleep apnea, my understanding is correctly that you can actually prevent it.
Well, Benadryl is actually, the advantage to Benadryl is that it's over the counter, it's not expensive, it's not addictive, and it actually does not affect your sleep architecture. So some of the medicines we give, like let's say Ambien, actually worsen your sleep architecture. You don't get as much deep sleep. Benadryl doesn't seem to do that. So it's actually a pretty good product. The problem with Benadryl is you get what are called the anticholinergic side effects: dry eyes, dry mouth, constipation, urinary retention. And so some patients with fibromyalgia have what are called the Sika syndromes, which is Raynaud's, dry eyes, dry mouth. That can make that almost unbearable for some people. Also, probably the biggest problem I see with Benadryl is it can worsen restless legs. And if restless legs is already irritating you and interfering with your sleep, adding the Benadryl may be enough to really kind of push you over the edge. So that can sometimes create more problems than solve. But in some people, it's effective. Yeah. Yes?
Following up on that, if there's no evidence of RLS, can Benadryl induce it?
Yeah, it can in some people. So it can unmask it. Yes?
With your epilepsy, that's a sudden loss of muscle tone?
Yes.
Like you can't move?
No, well, they can get what's called sleep paralysis. And so the question is about narcolepsy and the phenomenon called cataplexy. So in cataplexy, the story is when you're in REM sleep, your muscles are paralyzed, so you don't act out your dreams in the middle of the night and cry and ninja chop your partner or something like that. So your body turns the muscles off. So that can happen in patients who have narcolepsy right in the middle of their day. But it's typically triggered by something in the limbic system, your emotional system. So that can be kind of fright, anxiety, but it can be typically positive emotions, laughter, happiness. And when they have that, they may lose control of a limb. Now, the classic example is someone actually falls over, but they're awake and they just can't move. But it can be more subtle. They can just drop what they're holding. One eyelid can droop. So it can be sometimes very subtle to pick up.
Okay, so do you, in that, is it carrying over into one of the other types of somnolence if you are just blanking out at the same time?
Well, that's usually, that type of cognitive dysfunction is usually not associated with narcolepsy per se, and that's usually more indicative of some of the cognitive issues we see in people with chronic fatigue and fibromyalgia. That relates to how your cortex or your brain is operating. And when you sort of can't process information, it means something's going on a cortical level. And those are,
But I mean, this is like passing out, but there's a partial awareness, but it's like I can't move.
Right.
I have no, it's like I can't, my brain says like I'm going to sleep, but
Well, it could be. It's amazing. I've seen patients who've been referred for fibromyalgia and they actually do have narcolepsy. So I mean that certainly is a possibility. But anything that transiently affects your awareness, there could be a number of other neurological problems like epilepsy, migraines, sometimes panic attacks, and sometimes even cardiac issues like arrhythmia. So usually, if you go to a doctor's office and want to say, okay, if you're having any kind of transient alteration of awareness, epilepsy, migraines, panics, possibly TIAs or heart issues, can be something that we would want to rule out before we call it a benign condition.
okay, because I already know that I have migraines.
Sodium oxybate, one of my physicians had recommended it years ago, and it's the only thing we didn't try. I have narcolepsy and fibromyalgia.
Wow.
But I don't have sleep apnea, but I do stop sleeping frequently during the night.
Yeah.
Breathing, I mean.
Yeah. Oh, you stop
Breathing.
breathing. Yeah.
And when I go to sleep, I go immediately into REM.
Right. That's narcolepsy.
Yeah. So is there a danger of taking the sodium oxybate
If you have sleep apnea?
No, I don't have sleep apnea, but I do stop sleeping. Stop breathing. Yes.
Well, stop breathing is apnea. Do you mean it's not obstructive?
It's not
central
obstructive,
apnea?
right.
Okay. There's no exacerbation. So his question is about
Is it dangerous?
sodium oxybate and a type of phenomenon called central apnea. And I didn't go into that because that's a little bit more detailed. But central apnea is where you just kind of stop breathing on your own as opposed to obstruction. So sometimes any kind of muscle relaxant or sedative could potentially affect your muscle tone. So if you drink a bunch of alcohol and then go to sleep, you're going to have a little bit more snoring and you're going to have a little bit more apnea, obstructive. But central is where it just sort of happens by itself. I guess I should have mentioned it because it can sometimes be a problem in patients who are on high-potency narcotics. So a lot of times people with fibromyalgia will come in and they're on OxyContin or something like that. Now, narcotics will create central apnea because they blunt your respiratory rate. But if you just have a little bit of apnea, I wouldn't be too worried about using sodium oxybate. Now, there have been some studies that have shown, and I've seen this as well, an exacerbation of known obstructive sleep apnea if you add sodium oxybate. But it doesn't seem to change. We already knew they had sleep apnea. They're already on CPAP or something like that. It didn't really affect their management. So it never created a problem where there wasn't one, as far as we know. That may change. But it is important, if you're on that medicine, to follow up and maybe think about repeating the sleep study to see what the effect is, to be doubly sure. But it can be effective not only for the sleep problem, but not daytime alertness as well as the cataplexy. It's the only medicine that's been shown to help all those. Yes?
So the sodium oxybate is not approved by the FDA for fibromyalgia, is that right?
That's correct. What I would talk about was called a phase 3 trial that we're involved in, so that means not commercially available.
Right.
Based on the strength of this data, they did submit for an FDA approval, and evidently the recommendation was going to sort of come out in October. But I actually just heard just yesterday a rumor that the FDA was going to make a ruling in August.
Even though that's the case in your practice, you go ahead and prescribe it for people with fibromyalgia that have
Yes.
the right symptoms? Okay.
And it's called Xyrem?
Xyrem is the commercial name. Well, I mean, in neurology in particular, we've been using medications off-label for a long time. I mean, we use the Parkinson medication for restless legs for 15 years. We use medicines like Neurontin for peripheral neuropathy and shingles, for 15 years. So we typically, we kind of consider in neurology that these are neuromodulators. And so if we know that we can modulate something to a certain effect, we're going to use that medication.
Does the insurance ever give you trouble
Yes.
getting it covered?
Does the insurance give me... yes.
You know,
Does insurance? Yes.
So that gives you guys a lot.
XYREM is the commercial name.
Does it cause a sleep different?
Well, here's what's kind of interesting. You bring up an interesting question. So Xyrem is a medication that's designed to induce deep sleep, but it's actually not a drug for insomnia. So there's a little bit of a difference. So people with insomnia have difficulty getting to sleep and staying asleep. Now what Xyrem will do is if you are asleep, it will pull you down into your deep sleep. But sometimes the problem I have with the fibromyalgia patients is that they're so hypervigilant, they've got so much alpha intrusion, they're essentially awake. They'll take Xyrem and unbelievably they won't sleep on it. I mean it's unbelievable really. But I guess the idea is in fibromyalgia they're so wired to be awake that sometimes even this very powerful sleep drug will not induce sleep. But it will make them feel real funny, like they just, took a bunch of Valium or something. So it can sometimes be a very, very bad experience for patients with fibro if they're sort of counting on a good night's sleep and they're sort of awake and very altered and sedated. Yeah. So it can be. So sometimes, I'm sorry?
how often does that happen? I mean, do you have a
My experience, probably 5 to 10% of cases. And usually what you have to do is go ahead and titrate that dose up more quickly to get to a more efficacious dose. We may sometimes, rarely, although this is off-label, combine it with another sleep aid. In other words, get you to sleep so the Xyrem can do its work. So we may combine it with something mild and non-sedating, not something that potentiates GABA. So in other words, we would avoid things like Xanax or Ambien, but we might want to try something like Benadryl or let's say melatonin, because it works through different mechanisms. Yes?
So, I recently had a sleep study done, and I never went into REM sleep. And I also, they told me woke up like 26 times now.
Right.
And so I've been taking Ambien CR for a long time. I've been taking a lot of other medications.
Yeah.
And now I'm concerned maybe these medications are making that happen, and that's why I'm not sleeping.
Absolutely.
They've also suggested trying Xyrem.
Yeah.
So I just feel lost.
Absolutely. Well, it's a very classic situation where, you say if they have problems getting to sleep, and then the doc goes, okay, take Ambien. That's what I use. And then you come back and go, I'm not really doing that much better. Oh, you must be crazy. Well, no, we know why. Okay, we know why because you have alpha intrusions. You're not getting deep sleep, and if anything, the Ambien is keeping the alpha intrusions there and robbing you of your deep sleep. So it makes sense that you're not doing well on it. I mean, the science clearly is there right now to support that. So, we usually try to take people off those agents and onto other types of, agents. You might want to, I mean, the insomnia can be very, very significant in some patients with fibromyalgia. Sometimes we even use high-potency antipsychotic drugs to get people to sleep. So it can be that severe. But you need to, kind of learn about it and develop a rational approach. And if you're not having success with a particular program, you have to change and you have to research it. So things like this, I think, at the very least, should give us hope that they're doing very exciting and very intensive research on the sleep problem of fibromyalgia. So I think this tells us that there's going to be more things coming down the pipe that look like this, which is gives us more options, and that's what we need. Yeah.
The alpha intrusions, are they generated peripherally or centrally? Or?
I don't know. So the question is the alpha intrusion. So, and I think one question that sometimes comes up is this the chicken or the egg? In other words, is it the fact that you're kind of pulling an all-nighter that makes you irritable and fatigued and very painful, or is it the other way around? Is it the pain that's causing you to have a bad night's sleep? And no one knows that answer right now. And if anyone says they know that answer, they're lying because we don't have that answer. But the question is, this is an identifiable phenomenon. And, I showed the bubbles where I have the sleep and the pain and the hormones. So we know those things are going on. You can test those things. You can treat those things. So right now, sort of my pragmatic approach is just test it and treat it and see what happens.